So thank you very much for this kind invitation to give this talk on renal replacement therapy in critically ill patients and antimicrobial drug dosing. So here are my disclosures. So as Dr. Kota already mentioned, critical illness and sepsis will induce physiopathological alterations that will impact antimicrobial PK and mainly will have increased volume of distribution and altered clearance. And as mentioned previously, some patients will require organ support like renal replacement therapy that will further affect antimicrobial PK. And the challenges of antimicrobial drug dosing optimization in these patients are nicely summarized in this paper. We need to give these patients enough drug, but not too much, meaning that they are facing two opposite risks of underdosing and overdosing. And we'll see how we can face these challenges. The first studies highlighting the risk of underexposure in these patients was the IVOIR study that was conducted in France almost 10 years ago. This study compared two different renal replacement intensity, 7 milliliter per kilogram per hour compared to 35 milliliter kilogram per hour. And the authors did not find any statistical difference in terms of survival. And one hypothesis for these negative results were the lack of adjustment of drug dosing in these two groups, with a higher underdosing in the groups with the higher intensity of renal replacement therapy. And this underexposure may lead to clinical failure, and that's most recent data showing that, especially for a new antimicrobial drugs like here ceftazidime-avibactam, renal replacement therapy may represent a higher risk of clinical failure due to the risk of altered drug dosing in these patients treated with patients with high potential higher MICs. And we have really nice data for patients receiving renal replacement therapy from Jason Roberts and Jeffrey Lippman groups. We participated to the SMART study, which is a large cohort study. And we have PK data for these populations. And as you can see first from this study, we use different renal replacement modalities across the world, which made lead to increased complexity for drug dosing adjustments. Because as you can see, for different beta-lactams and for vancomycin, the impact of renal replacement modality may differ, and we can see here for meropenem that the different modalities will not have a significant impact on concentrations, whereas for vancomycin here, techniques with diffusions will lead to higher concentrations. But most of all, the main key message from the SMART study is that we have a really high inter-individual variability, as you can see here for piperacillin tazobactam, with a large range of concentration in this patient. And this may explain why it is difficult for clinicians, for intensivists, or for pharmacists to provide adequate drug dosing for all patients on renal replacement therapy. And we have this recent survey from France here on the left side, where you can see for meropenem as an example, we have very large differences in terms of drug dosing for these patients. And this, we have similar data here for sustained low efficiency dialysis. When we ask pharmacists the recommended meropenem regimens, you can see a large variability. And this may be really well explained by the complexities of these patients. The complexities relies on the different factors that may affect drug dosing. Factors related to the patient himself, the volume of distribution, his weight, or the renal residual functions, and we'll come to this later. Factors related to the drug and its molecular weight, its physicochemical properties, the protein binding, and the factors related to the RRT modality you use in your unit and the settings, and also adsorptions and filter lifespan. So many factors that may affect antimicrobial PK, and this lead to complexities in drug dosing. So we need general rules for RRT dosing. And the first rule is that continuous techniques compared to intermittent hemodialysis will induce a more physiological elimination and might be easier using these techniques to adjust drug dosing. If we look into intermittent hemodialysis data, you can see that there is large variations in clearances across the different period, and you have the elimination on dialysis, and you also have the interdialytic elimination rate that may be very different. And when we try to model the concentrations for these patients, you can see a large variability over time, which may be more complex than using continuous renal replacement therapy. And you can see, especially when using regional anticoagulations with citrates, that the dialysis dose is much more stable over time with this kind of techniques. And so to prefer continuous techniques for renal replacement therapy, we may also prefer continuous infusions for beta-lactams due to continuous elimination of the drugs related to continuous renal replacement technique. And we have data showing that using continuous infusions of beta-lactams will increase the proportion of patients achieving the PK/PD target of 100% of the time above 4 times the MIC compared to intermittent bolus, here's for piperacillin. And we also had similar data in our study we conducted some years ago, and we looked at patients receiving, it's quite small number of patients, but we looked at patients receiving in equal dosing of dialysis was continuous veno-venous hemodialysis filtrations or continuous veno-venous hemofiltrations, similar dosing, and we showed that continuous infusions of piperacillin tazobactam was able to maintain the concentrations above the highest MIC. So probably continuous infusion of beta-lactams in continuous RRT is the optimal mode. The second general rules to keep in mind in RRT dosing is that the amount of drug removed by these techniques will mainly depend on, first, the physicochemical properties of the drug you use and the effluent rate applied. Meaning that for dosing adjustment, it's not required for all the antimicrobial drugs you use. And dosing adjustment is unnecessary if physiologically the drug you use, the renal clearance is above 25 to 30% of total drug clearance. The second important characteristic is that for high protein bound molecules, up to 80%, like oxacillin, cefazolin, or echinocandins, you don't need to adjust adjust drug dosing. And finally, lipophilic drugs are at low risk of underexposure for CRRT patients. So we can sort of predict the impact of continuous renal replacement therapy on drug clearance based on these properties. And you can see that there are high risk molecules like aminoglycosides or the new ceftolozane, tazobactam, antimicrobial drugs, and vancomycin that may be at high risk due to low protein binding or low volume of distribution. On the opposites, most of lipophilic drugs have CRT have a not significant impact on their clearance. So we will focus on hydrophilic drug dosing adjustment because, as I said, they're at higher risk of underexposure. And so there's two main characteristics that you have to keep in mind is, should I adjust loading dose? Should I adjust maintenance dose while my patient is on CRRT? And you need to remember, but most of you know, that the loading dose mainly depends on the volume of distribution. And in septic patients, this volume of distribution is increased. So meaning that for these patients on CRRT, we need to use higher loading dose, and it's independent from the CRRT techniques. Whereas for the maintenance dose, it mainly depends on the elimination of the hydrophilic drugs, and the two key components of these eliminations are residual renal function for your patients and CRRT intensity you applied. And we have studies showing these correlations between CRRT intensity and beta-lactam drug clearance. And you can see this correlation. The higher the intensity of CRRT and the higher the drug clearance induced. But the impact may, in terms of dosing adjustment, may differ based on the killing properties of your drugs. And you know that there are concentration-dependent antibiotics like aminoglycosides and time-dependent antibiotics like beta-lactams. And so the impacts will differ. For aminoglycosides that are concentration-dependent, we'll use, it's what we shown in this study using a sophisticated population PK analysis. And we demonstrated that for these patients, we need to use high dosing to ensure efficacy, but we need to extend the dosing interval to limit the toxicity. And based on the results of this population PK analysis, we found that the optimal dosing in this population was a 25 milligram per kilogram dosing regimens every 48 hours. So for hydrophilic drugs and concentration-dependent drugs, you need to use high dose and extended interval. On the opposite, for hydrophilic drugs and time concentration characteristic, it's the impact of the effluent rate you use that will help you to choose the better maintenance dose. And as an example here, in this study, looking at cefepime concentrations on CVVH, you can see here that using the similar dosing regimens, but increasing here the ultrafiltration rate from 1 liter per hour to 2 liters per hour will induce subtherapeutic concentrations. And this is for CVVH, but we have exactly similar data for all RRT modalities. And this is data from ex vivo studies, but we see exactly the same correlations between here the ultrafiltration flow rates and the clearance related to CRRT. We have similar data for hemodialysis, and in this case is the dialysate flow rate that will mainly impact the clearance of the antimicrobial you use for hydrophilic drugs. So you need to, at bedside, keep in mind that if you use different effluent flow rate, and here is an example for the meropenem, that you will have to increase your drug dosing, because as you can see here, if you use, as an example, 30 milliliters per minute effluent flow rate, and you decide to use higher intensity for your patients, then the clearance related to CRT will be twice higher. So meaning that you need to also adjust the maintenance dose for these patients. So to first summarize these general rules, when you need to adjust drug dosing for your patients, you need to consider the physicochemical properties of the agent you use. And we've seen that it's mainly hydrophilic drugs that have high risk of inappropriate drug dosing, and you need to consider their killing characteristics. So for hydrophilic time dependent, you need to use high loading dose, continuous infusion, and adjust the maintenance dose to the effluent rate you use in your patients. Whereas for concentration dependent agents, you use increased loading dose and you adjust the dosing interval to your effluent rate. But drug dosing adjustment in these patients, it's a bit more complex, because there's other factors, as I mentioned previously, that may also affect drug dosing, and the type of hemofilter does matter. We have data for vancomycin here showing that the impact of the membrane can be significant on vancomycin clearance, with a higher clearance for here polysulfonopolyamide filter. And more recent data show that protein adsorption is particularly high for AN69 membrane, meaning that you need to consider in your unit the membrane you use for your patients and pay attention, especially if you use AN69 with some drugs like aminoglycoside, because you may have adsorption phenomenon. And so when you look into the data available in the literature, here, for example, for vancomycin, you need to take attention at the modality of RRT used in the study. And you also need to see which hemofilter they used. And here you can see in this study that for a quite common RRT setting for CVV HDF with an effluent rate of 26 milliliters per kilogram per hour, the optimal vancomycin dosing was a loading dose of 25 to 30 milligrams per kilogram and a maintenance dose of 10 milligrams per kilogram in 24 hours. So that's the kind of information you can use to better optimize drug dosing for your patients. You also need to consider the hemofilter lifetime. And now that we have techniques like continuous renal replacement therapy with regional citrate anticoagulations, the lifetime of our hemofilter is much, much longer, which is quite good. But we can have saturation process and absorption that may expose our patients to overexposure. And in this study, looking at the concentrations for a filter that was less than 24-hour lifetime compared to filter above 24-hour lifetime, you can see that the concentrations was much, much higher. So it's another factor to take into account. And finally, as I mentioned earlier, the residual renal function of your patient may also affect the clearance of the drugs and may require to adjust and to increase drug dosing. And that's what showed this study using, again, a population PK analysis for meropenem. And you can see that for 500 milligrams per kilogram per 8 hours, that dosing regimens achieve the PK/PD target for patients that are anuric. But for patients that have preserved diuresis and urine output above 500 milliliters per 24 hours, these dosing regimens may not be sufficient and may need to use prolonged infusions or a higher drug dosing. So this is another factor to take into account for your patient, especially when the renal function recovers and the urine output increases. And finally, in the general rules for drug dosing on CRRT, you need to also remember that continuous is not really continuous for our patients, and we have off RRT periods. And for prolonged RRT periods, we also need to reconsider antimicrobial drug dosing. And what often happen in real life is that our patients develop AKI and require continuous renal replacement therapy with quite appropriate drug dosing and plasma concentration of the drug. And then we decide to stop CRRT to see whether our patients and the renal function of our patients is recovering. And then if we do not adjust drug dosing, then we can expose our patients to over exposure and mainly toxicities that may have clinical consequences and especially neurotoxicity for beta-lactam. So for all these reasons, we do need to have therapeutic drug monitoring available at bedsides to better optimize. As we've seen, there's so many factors that will impact antimicrobial PK that we need more sophisticated tools. And I was lucky to participate to these French guidelines on optimizations of beta-lactam antibiotic in critically ill patients. And the experts suggest to perform TDM, especially in these patients, very complex patients undergoing renal replacement therapy. And this is also emphasized in the ESICM paper published a year later. And I think the presentations before convinced you that we absolutely need TDM for critically ill patients, but in particular for CRRT patients. When we look at the data available in the literature, we can see that TDM help clinicians to sometimes increase the dosing, but mainly in 25% of the patients in this study looking at beta-lactams TDM, the therapeutic drug monitoring encourage clinicians to decrease the dosing due to overexposure. And I think this is the main risk for these patients to be exposed to toxicity. And we do know that some beta-lactam, and especially like cefepime, are a higher risk of inducing neurotoxicity in our patients. And you can see here from this recently published study that that's a quite narrow therapeutic window for cefepime with trough concentration between 8 and 32, and you can see here the probability of neurotoxicity in this window. And when we look at the main risk factors for inappropriate drug dosing, renal function is one of them. So we really need to be careful, and especially in the later phase of sepsis. And this is other data on TDM in this population of patients on CRRT. And you can see that for early TDM, the concentrations here for piperacillin tazobactam are adequate, but if we do repeat TDM after 48 hours, you can see that the concentrations may increase quickly and be really high and potentially toxic. So that means that we need TDM, we need to repeat TDM and to limit the risk of toxicity. But as we've seen with the previous presentations, probably TDM is not enough to optimize drug dosing in these challenging populations. And we need new tools, and we need dedicated dosing software. And this is one of the software you can also use at bedside. The Tudamix is freely available. It's one of them, but as you've seen previously, there's many softwares available where you can include the characteristics of your patients, its dosing history, and then you can predict the concentration and choose the optimal drug dosing. And in particular, in CRT patients, this may be really helpful to achieve better achieve PK/PD target in this population. And we have very few data focusing on this population. We have data for vancomycin here, and we can see that after the second measurement, using Bayesian software, we increased the results show that they increased target attainment in this challenging population. So that's a promising approach. So to conclude, we need to further individualize drug dosing in CRRT and optimize drug dosing, and probably in the next future, Bayesian forecasting and dosing software will help us to take into account the patient's characteristics, the MIC, the RT settings apply, potential difference in terms of membrane, residual renal functions, to better adjust drug dosing and to individualize drug dosing in these patients. And as I mentioned, we'll need to reassess across the course of antimicrobial therapy to adjust drug dosing and to better optimize, and probably will hope to show that this may help us to improve our patient outcome. Thank you for your attention.
Thank you, Claire.